This is your lecture on antidysrhythmic drugs. Antidysrhythmics are used for the treatment and prevention of disturbances within the cardiac rhythm. You are not expected to know this in depth, as this would be a more advanced skill to have, but it is important that you understand the cardiac cycle, as this should be a concept that you learn in physiology, with also understanding the electrical activity and how that pathway occurs throughout the heart. Dysrhythmias occur when there's a deviation from the normal rhythm of the heart. This can be for a multitude of reasons. It can come with many conditions, after a myocardial infarction, cardiac surgery, or as a result of coronary artery disease. Typically, it's serious and requires treatment with either antidysrhythmic drugs or non-pharmacologic therapies. If it is severe enough, we may have to do something called cardioversion or transcutaneous pacing to get them out of that abnormal rhythm. Typically speaking, these dysrhythmias are going to occur as the result of abnormally functioning cardiac cells. You should be familiar with resting membrane potential as well as action potential, including the aspects of action potential, including what your SA and AV node do, as well as their rate. This again should be information that is pulled forward from your physiology course. When we talk about antidysrhythmic agents, we're looking at medications that are categorized based on where and how they affect the cardiac cells. There is a classification system called the Vaughan Williams classification. It is a category of 4 classes of drugs from 1 through 4, and we will go through each one. Antidysrhythmic drugs are going to work by correcting abnormal cardiac electrophysiologic function. We will utilize these medications for dysrhythmias, and it would be contraindicated in anybody with a second or third degree AV block, bundle branch block, cardiogenic shock, sick sinus syndrome, any other electrocardiographic changes depending on the clinical judgment of the cardiologist. For adverse effects, all of our antidysrhythmic agents can cause dysrhythmias. We can also expect to see nausea, vomiting, diarrhea, dizziness, headache, and blurred vision. There is also a high risk of prolongation of the QT interval, which could lead to torsades. For toxicity and management of an overdose, there is no specific antidote, so we have to focus on the maintaining of our circulation and airway with supportive care. One thing we need to be particularly focused on is the fact that there is a very big interaction with Coumadin. We need to monitor our patient's INR, or international normalized ratio, as it can increase our Coumadin levels and prolong our INR by almost 50%. This means the patient is at a very high risk for bleeding, so we need to monitor this extremely close. There's also an interaction with grapefruit juice, as well as amiodarone, disopyramide, and quinidine. Those are our general overview for our antidysrhythmic drugs. Now we are going to delve into our Class 1 antiarrhythmic drugs. They're also broken down into Class 1A, 1B, and 1C. Starting with 1A, our prototype drug is quinidine, or Quinidex. This drug has direct action on electrical activity of the heart and indirectly anticholinergic effects. It can cause cardiac asystole meaning no beat whatsoever, so that is a cardiac standstill, and ventricular ectopic beats. We can also have synchronism, which is a collection of symptoms that is caused by quinidine, characterized by tinnitus, loss of hearing, blurred vision, and GI upset. There is also a black box warning for torsades de pointes. For our Class 1B drugs, our prototype is lidocaine or xylocaine. This drug is effective for managing ventricular dysrhythmias. We have to give this IV because there is an extensive first-pass effect. We do also need to be mindful of our dosing in our hepatic failure patients and also possibly renal failure. This does also raise the ventricular fibrillation threshold through decreasing sensitivity of cardiac cell membrane to the impulses. This then decreases the cell's ability to depolarize. Adverse effects to monitor for include twitching, convulsions, confusion, respiratory depression or arrest, hypotension, bradycardia, and dysrhythmias. It is contraindicated in anybody with severe SA or AV block, Stokes-Adams or Wolff-Parkinson-White syndrome. Moving into our Class 1C drugs, our first drug, flecainide or Tambicor, is the first-line drug in treatment of atrial fibrillation. It does have negative inotropic effects that depresses the left ventricular function. Adverse effects to watch for include dizziness, visual disturbances, and dyspnea. It's contraindicated in anybody with cardiogenic shock, second or third degree AV block, and non-life-threatening dysrhythmias. Our next drug, propafenone or Ridmol, does have similar actions to flecainide, but it does have mild beta blocking effects. We should avoid these in patients with bradycardia. We do use this for life-threatening ventricular dysrhythmias and atrial fibrillation. Most commonly reported adverse reaction is dizziness. Patients can also complain of having a metallic taste, constipation, headache, nausea, and vomiting. Our Class 3 drugs, our prototype here is amiodarone or cortisone or pacerone. This drug is going to prolong the action potential duration and refractory period in all of our cardiac tissues. It's going to also block alpha and beta adrenergic receptors of the sympathetic nervous system. We use this for sustained ventricular tachycardia, ventricular fibrillation, and non-sustained ventricular tachycardia. This is also in our Advanced Cardiac Life Support Algorithm, or ACLS. Adverse effects we need to be mindful of are corneal microdeposits that can cause visual halos, photophobia, and dry eyes, as well as photosensitivity. This drug can also cause pulmonary and hepatotoxicity, as well as proarrhythmic effects. It is also lipophilic, meaning it penetrates and concentrates in our adipose tissue. Because of the similar structure of iodine, in chemical nature, it can induce hypo or hyperthyroidism, so we must always get a baseline and assess throughout therapy. We also need to be mindful that digoxin and INR levels will increase by 50%. This could potentially be fatal, so we need to monitor this extremely closely. It is contraindicated in anybody with severe sinus bradycardia or second and third degree heart block. And our next class are the unclassified antidysrhythmics, covering adenosine or adenosine. This drug is going to slow conduction through the AV node. We use this to convert supraventricular tachycardia to a sinus rhythm. It has an extremely short half-life, which is less than 10 seconds. I've given this medication a handful of times, and what you have to do is get 2 saline flushes, and you have to push it concurrently with the medication to see an effect. Very important that your patient is hooked up to the monitor, and you absolutely have to have a physician at the bedside. Reason being, this will induce asystole. You're resetting the electrical conduction of the heart. It does restart, but you will see a flat line. The patient is not going to feel good either, so you want to let them know what's happening. Tell them what to expect because it can be very scary. Essentially, they're dying for a few seconds, and then the heart rate will restore. So please make sure you always have your safety parameters. I remember a situation where I responded to a rapid response and the cardiologist wanted us to give adenosine. And I responded with, hospital policy is there must be a physician at the bedside. Will you be coming to the bedside? To which they began to argue that they did not need to because this drug is actually a part of the ACLS, Advanced Cardiac Life Support Algorithm. I said, while that is correct, this drug is actually written in our policy that you must have a physician at the bedside due to the patient going into a brief asystole and possibility that it may not return to a normal sinus rhythm. And that does happen. So a physician needs to be at the bedside. We ended up having to get the house supervisor involved, and it was quite a big fiasco. We ultimately did get a physician and were able to reset basically the patient's heart, and they went back into a normal sinus rhythm. But this is a medication that you do want to take very seriously.